So what have we got up next? We have our next speaker. So we have Associate Professor Jo Robinson, which is exciting. She works both at Melbourne University and as the Head of Suicide Prevention Research at the Youth Mental Health Service at Orygen. Orygen do amazing stuff. I've seen some of the content they have for groups they run to address anger and anxiety. So I look forward to hearing Jo speak. Over to you, Jo. Thank you so much.
Hi, everybody, and thanks so much for having me here today. I'm Jo Robinson, and I lead the Youth Suicide Prevention Research Group at Orygen, which is part of the University of Melbourne. Before I get going, I would like to acknowledge the traditional owners of the lands that I'm joining you from here today, the lands of the Yalukit Willam people of the Boonwurrung, and pay my respects to elders past, present, and emerging. I'd like to extend that acknowledgement and respect to the traditional elders of the lands that others are joining us from today, and to any Aboriginal or Torres Strait Islander people in our audience. So thank you and welcome. So today I'm going to be talking a little bit about some of the work we're doing in my team in youth suicide prevention. And this is what we'll try and get through, and we'll see how I go for time. But I'll give you a little bit of an overview around what's happening in terms of the epidemiology of suicide and self-harm in young Australians and some of the risk factors that we're seeing. And then what I'll do is give a bit of a snapshot of some of the work we're doing around youth suicide prevention in different settings. And I'll talk a bit about online settings, school settings, and then in the clinic. And I'd like to finish, if time permitting, with just a couple of words really about youth participation in suicide prevention, and specifically actually suicide prevention research. Okay, so let's get into it. So in terms of background, unfortunately, suicide is the leading cause of death amongst young people here in Australia. And what you can see from the graph here is that suicide rates have been steadily increasing in young people over the last 10-year period. So as you can see, so this graph here, this line here is for young males aged 20 to 24, steady increase, same for young males aged 15 to 19. We're also seeing lower numbers and lower rates, but also a similar trend in young females, in particular females between the ages of 15 and 19. And in fact, we're also starting to see increases in suicides in females even younger. And that means that suicide is the leading cause of death here in Australia. And as I said, rates have been rising over time. If you look at the rates here, what you can see is overall in 2020, there was just over 3,000 deaths, suicide deaths across Australia, across the age range. 381 of those were by young people. So what we see is a rate of 12, just over 12 per 100,000 population across the age range. But when you look at young people, and in particular young males, what you see is a rate of nearly 25 per 100,000. So significantly higher rates in that younger cohort, particularly young males. Rates are higher generally in regional areas compared to the capital cities, with the exception of South Australia, I think. And tragically, twice as many First Nation Australians die by suicide compared to their non-Indigenous counterparts. So we definitely need to be doing a better job of looking after our Aboriginal and Torres Strait Islander young people. We also see high rates in young people who identify as LGBTQIA+, although I have to say that the quality of data collected around mortality in this population is pretty limited. And again, we could do with doing a bit of a better job of recording what's happening across different sectors of the population. And just finally on this, I'd just like to note that youth suicides are over twice as likely to occur as part of a suicide cluster than adult suicide. So that's from some work that we did here in Australia, the mapped suicide clusters across Australia a few years ago. And youth suicides accounted for over 5% of suicide deaths compared to 2.5% in adult suicides. So here we're looking at self-harm. We know self-harm is one of the biggest risk factors for future suicide. And young people do have the highest rates of hospitalization for self-harm across the population. So here what we start to see are these higher rates amongst young females. So as I was saying before, rates of suicide tend to be highest in young males, although rates in females are increasing. And what we're seeing here is sort of the reverse of that, where we see higher rates of self-harm in young females, but actually increasing rates of self-harm in young males. And I'll show you a couple of graphs in a second that show what's been happening over time. But as you can see here, around a quarter of young women report self-harming at some point in their lifetime. And this is young women up to the age of 24. And in males, lifetime rates are around 18% in the 20 to 24-year-old age bracket and 11.6% in the slightly younger age bracket. We do see particularly high rates of self-harm in our clinical samples. And self-harm typically onsets around that period of early adolescence, around the time with puberty, associated with puberty. And although for many people it does remit with age, it is distressing in its own right and associated with a whole range of other negative outcomes, including subsequent self-harm, but also subsequent death by suicide. So it is a behavior or a problem that we need to be taking seriously when it does occur. We've also heard reports, and I'm sure many of you will have heard these too, certainly across the media, significant rise in rates of young people presenting to the emergency department with self-harm during the course of the pandemic, and also some evidence to indicate increased use of mental health services, increased psychological distress, and to a certain extent, particularly in these younger populations and young males, increased rates of youth suicide as well. So this gives a little bit of a snapshot of what's been happening over time. So these are ambulance attendances from the period of 2018 up to 21. So it's just this last couple of years across the age range. And again, you can see here, this is young males, steady increases, but quite striking increases in young females. So these are ambulance attendances for self-harm. We've got similar data that's also for suicidal ideation and suicide attempt, and the same pattern is seen. So these really striking increases in young females under the age of 24. And this next chart here talks about hospitalizations for self-harm. So again, this is the graph for young males, or for males across the age range actually. And this is the graph for females. And again, quite striking that the highest proportion of hospitalizations for self-harm are occurring in young females. And this is the age group under like 15 to 19, so particularly high. And this is the group for the 20 to 24-year-olds. So what you can see here is we've got this problem basically with increasing rates of distress, increasing rates of self-harm, high rates of presentation to hospital and hospitalization for self-harm, and high rates of, or increasing rates of suicide amongst young people. So in terms of some of the risk factors, what you can see here, and as I just said, the history of self-harm or previous suicide attempt is the strongest predictor of subsequent risk of suicide across the population and including in young people. And I think what I always take away from this is that, as you've seen from the previous slides, a lot of these young people are seeking help. But unfortunately, what we know is when they do seek help, they don't always get the help that they need. So one of the take-home messages for me always is if we're seeing young people presenting with self-harm or suicide risk to any clinical service, or in fact to any help, source of help, we need to be taking that behavior seriously and then providing them with the support that they need, whether that's clinical support or social support or what have you. We also know that the other most common risk factor for suicide and self-harm is mental disorder, most commonly depression, and that's often mediated by a sense of hopelessness. And you can see that there's all sorts of other traits here that are also associated with suicide risk and self-harm risk in young people, including behavioral things like poor problem-solving skills, coping skills, exposure to suicide or suicidal behavior in others. So that's that point I was making before about suicide clusters. And then there's issues around childhood adversity and lack of social support and conflict. And the thing that I would say about all of these, although, I always feel mindful that I tend to kind of be presenting this picture of hopelessness, this kind of a story of doom and gloom, but actually what all of these do is provide an opportunity for intervention. So we can intervene effectively when people present with self-harm. We can treat most mental health problems. We can kind of relieve this sense of hopelessness through good clinical care. And we can teach people and engage them in problem-solving skills, coping skills. We can help them manage some of the difficulties associated with some of these other factors. So it's not a story of doom and gloom. I think all of these risk factors actually present an opportunity for intervention. So what might a framework for intervention or prevention look like in suicide prevention? So probably this framework will be familiar to most people. It's a framework that's commonly applied to mental health promotion and prevention. And we use it a lot in suicide prevention as well. So here what we've got at the bottom of our pyramid are universal approaches that really target the general population regardless of risk. So the appeal of a universal intervention is that you can target a whole population group, so you can reach large numbers of people and potentially reduce suicide at that population level. And typical kind of suicide prevention approaches that sit in this universal category include things like restricting access to means, which has been shown to be an effective suicide prevention strategy, implementing media guidelines to promote safe communication about suicide, public education and media campaigns to raise awareness and promote help seeking, and educational workshops, often delivered in school settings when we're talking about young people. Then as you move up your pyramid, you get to these sort of selective interventions, which start to target groups that might be at elevated risk of suicide. So they might be the people I was speaking about before, people who are presenting with mental health problems, or people who have been exposed to the suicide of a friend or family member. And so these sorts of interventions were obviously reaching a smaller sector of the population, but our responses are getting a little bit more targeted to those people who we know might be at risk. And these typically include screening or case detection kind of interventions, and things like gatekeeper training to better equip people to identify and support people who might be at risk. And then we get to the very top of our pyramid, this sort of pointy end, where we're delivering indicated interventions to those people who are already showing signs of being at risk of suicide. So they might be presenting with suicide attempt or suicidal ideation. And these typically involve referral to clinical services, psychological and pharmacological treatment, and so on. And in young people, what we tend to see are a lot of these universal interventions are often delivered in school settings. As I was saying, they might be universal education programs delivered to cohorts of school students. They might be combined with screening interventions or case detection interventions to identify those young people who might be at risk. And these are interventions that we've tested ourselves, and I'll talk a little bit more about, that have been shown to be safe and effective with young people. We, as I said, gatekeeper training is often seen to be effective, but I would argue strongly that it shouldn't just focus. Typically, this would focus on teachers or school wellbeing staff, but we should be certainly thinking about including other young people and family members in here. And we do know that online treatment can be safe and effective when delivered to young people at risk of suicide. But what we also know is those interventions are most effective when delivered together and across settings. So we did a big systematic review and meta-analysis a few years ago now, which kind of underpins a lot of the work that we're doing in my team. We looked at interventions that were delivered across community settings. Here you can see that there were 16 of those studies. None of them were randomized controlled trials, but what we did see was that those multimodal or place-based interventions did seem to have positive effects. And what we mean by multimodal is those sorts of interventions that were implying all the different strategies that I was talking about in that framework. And they did appear to be having some effect on reduced suicide rates. We looked at interventions in education and workplace settings, and again found that school-based psychoeducation and screening interventions did appear to be showing promise. And many of the clinical interventions we looked at too also appeared to show promise in terms of reducing the frequency of both self-harm and suicidal ideation. But there were some gaps. So there was no studies that we identified that were conducted in primary care settings. There were very few studies conducted in tertiary education or workplace settings. There were very few studies conducted online, which, given the amount of time young people spend online, we thought was a bit counterintuitive. There were very few studies that were conducted with vulnerable populations. So I'm thinking now back to the groups that I mentioned at the very beginning. So First Nations young people, LGBTQI plus young people, and that also included young people on the autism spectrum disorder. So very few studies targeting those populations. And very few studies were designed by or for young people. A lot of these studies were designed for adults, or a lot of the interventions being tested were designed for adults and just being adapted or applied to young people. So I'm going to give you a little bit of a snapshot, and it will be a whistle-stop tour of some of the work we're doing across these different settings. So the first example I'm going to give you is some work we're doing in social media. So it sits in that universal category. It's targeting whole populations regardless of risk. And it's really designed to mitigate some of the risks that are associated with talking about suicide on social media platforms, but maximizing some of the benefits. So you can see here, there are lots of benefits that young people talk about when it comes to communicating about suicide online, the 24/7 nature of social media. They find it accessible and appropriate and acceptable. You can reach large numbers of young people quite quickly at relatively low cost. So lots of benefits. But we also know that there are some challenges, and we know that there are certain types of communication that might occur on social media that might be unhelpful, particularly when it's sort of exposure to harmful or negative content that might lead to that possibility of what we refer to as contagion, that might increase the risk of suicide, subsequent suicide deaths and clusters. But what we were hearing from young people and the suicide prevention sector were the positives outweighed the negatives when it did come to social media. So young people told us loud and clear that social media needed to be part of the suicide prevention landscape going forwards. So we worked in partnership with young people and the suicide prevention professionals to develop the ChatSafe guidelines. I suspect many of you are familiar with these now, but they were developed using an expert, Delphi expert consensus process a few years ago. They really are designed to help young people feel better equipped to talk about suicide safely on social media platforms. They're designed around the ways young people told us they did use social media to talk about this subject. So there's sections here on how to share your own thoughts or feelings in a safe way. There's sections on how to respond to somebody else that might be suicidal, and sections on how to memorialize or talk about somebody who's died by suicide in a safe way. The guidelines are freely available, so by all means have a look at them. They're freely available on the Origin website. But we also know, even though they were quite innovative at their time and designed very much in partnership with young people, they're probably not that youth-friendly. So we then worked with young people from across Australia to co-design a national social media campaign that we then rolled out in partnership with young people across various social media platforms. So I think Snapchat was our best performing channel, but Facebook, Instagram, YouTube, Twitter, Tumblr, and so on. And this just gives you a little bit of a flavor. I haven't got time to go into all the content now, but this gives you a bit of a flavor of what the Instagram page looks like and what the content looks and feels like. But we were quite concerned, and this was some of the feedback we got from young people, very concerned to make sure that young people gained knowledge from the content. It wasn't just an awareness campaign, it was actually very much an education campaign. And we also did some evaluation of it. So you can see here, it reached lots of young people. It reached about 5 million young people. The guidelines themselves and some of the associated resources we developed for adults have been downloaded over 100,000 times. And the ChatSafe intervention did appear to improve young people's willingness to intervene against suicide online, so help them feel better equipped and able to support their friends. And it also helped improve their self-efficacy and confidence and safety when it came to online communication about suicide. They also reported being less likely to share harmful content, more likely to monitor their posts. So that all presented a promising picture for the acceptability and potential impact of a universal social media campaign about suicide for young people. So we're currently doing a little bit of work now to update the guidelines and also to include self-harm. We're trialing them. So I presented just then some pilot data from a universal study, but we're about to launch a randomized control trial, and we'll also be testing them in more vulnerable populations as well. So thinking about using them as a selective and indicated intervention, and we're about to expand our work into school settings as well. So that gives me the perfect segue to talk very quickly about some of our work in school settings, which is the study called the MAP study, which is a multimodal approach to preventing suicide in schools. So as I explained a little bit earlier, the systematic review we did really showed that school-based studies seemed to be effective when we were combining things like large-scale psychoeducation programs with case detection programs to identify suicide risk in themselves and their friends, and to respond. So we partnered up with Lifeline Australia. They were delivering the training and we were evaluating it for them. And we also developed a screening measure and built that into the evaluation to make sure that delivering training to young people in school settings didn't cause harm. And what we found was that it didn't cause harm. There was no evidence of iatrogenic effects. Young people liked it and they found it acceptable. And it also increased their knowledge, their confidence, and their willingness to support others. As part of the screening measure, we were also able to identify quite a significant portion of young people who needed support, and we were able to refer them on to the school counsellor and the local headspace centre for help. So we piloted all of that a couple of years ago now. We also piloted an online cognitive behavioural therapy program called Reframe It, which we developed at Origin. And as I say, we piloted this in a couple of different schools in our local area in northwest Melbourne, and again found positive effects. So I can't go into the details, but it's an eight module, 15-minute video-based CBT program. And what we found here was that there were no negative effects, again, as per before. And we found that suicidal ideation, depressive symptoms, and hopelessness decreased as a result of receiving the intervention, and problem solving and coping skills increased. So, aligned with what the evidence is telling us is best practice, we've now combined all of those interventions into one large-scale study, where, again, we've partnered up with Lifeline and LivingWorks. We're delivering Safe Talk training to all Year 10 students, or we're offering it to all Year 10 students in schools across the northwest Melbourne. We'll be screening all of those students to identify any students at risk and referring them on to make sure they get the help that they need. And we'll also be then feeding those young people who are at risk and who consent into a trial of the Reframe It program that will be delivered to around 200 school students across the region. In addition to that, and because this is a really important part of the puzzle, we're also offering assist training for nominated school staff members and start training to parents of students. And we've trained about 200 parents so far. So taking a very holistic approach to building capacity across school settings in our region. So again, that was, about a whistle-stop tour of what we're doing in schools. And I'm obviously happy to take any questions about that if people have them. But I just wanted to sort of start to wrap up a little bit by talking just briefly about a piece of work that one of my postdocs has been supporting a master's student to do, which is a qualitative study looking at their experience of feeling suicidal and self-harm with young autistic people who have come through Origin's clinical services. So this is sort of very hot off the press. Linda's still writing up her thesis as we speak. But the aims of this study were really, again, we were hearing very much from our clinicians that this was a population who were very much in need of support, and perhaps where suicidal behaviour and self-harm looked and felt a little bit different to other young people that were coming through the clinics. So we aimed to set out to examine what young people's experience was of these behaviours or these feelings, the relationship between suicidal ideation and self-harm, their experience of seeking help, and whether those experiences were influenced by gender, either their own gender or the clinician's gender. So we did some qualitative interviews with 5 young people who had come through our clinic. And I'll just give you a real snapshot of some of the high-level findings. So what you can see here is these were some of the key themes that emerged from the study, that interpersonal and intrapersonal understanding facilitated that connection to both the individual themselves and to others, including their clinician. Suicide and self-harm both arise from that real intolerance or inability to tolerate difficult or intense emotions. And suicidal or self-harm actions tended to be quite quick and impulsive, but also led to a level of meta-distress, or they were distressing in and of their own right. And I have to say, this probably isn't exclusive to young autistic people, but possibly more pronounced or harder to process for this population. And the other high-level theme that Linda identified was this duality of relating to others. The connection within that therapeutic relationship really tended to be slow and complex, and really tended to impact on the therapeutic experience. And so some of the takeaways from this study were that suicide and self-harm were really used as emotion regulation tools to escape really unbearable situations. There's this idea of kind of really increasing intrapersonal understanding could protect against self-harm and suicide. And we really need to be flexible and think about what the needs are of young autistic people when we're delivering services or mental health-based interventions across our clinics. And we really need to be including these young people in co-designing what some of the solutions might be for them. And I think that brings me just to the kind of final point I want to make, which is about youth involvement in suicide research. So look, I think we've done a really good job in suicide prevention over recent years of involving people with lived experience in the sector. And I think probably more and more across mental health services, we're also doing a good job of partnering up with young people when we're co-designing services and mental health interventions. But I don't know that we've done a very good job of partnering with young people when we've been doing suicide prevention research. And I think that that would extend to young people on the autism spectrum. So we're doing some work now where we're trying to redress that. We think that young people have got a lot to contribute. And I think as long as we put the correct safety mechanisms in place and look after their well-being, we think that actually it's critical that we are partnering up in a better way with young people going forward. And I also think that I showed you at the very beginning some of those graphs that were showing these increasing rates of suicide and self-harm in young people. We've had a lot of investment over recent years in suicide prevention efforts, but I'm not sure that they're really hitting the mark with young people. And I suspect that's because we're not partnering with them in designing the solutions and strategies for them. So in this study here, we're really aiming to develop and distribute a set of best practice guidelines to help guide youth partnerships in suicide prevention research. We're again using a Delphi expert consensus methodology, and we'll have a couple of panels of experts, which will include suicide researchers and young people. And hopefully that those activities will lead to a suite of outputs, including guidelines and supporting resources, partly for researchers to help us feel better equipped or have some guidelines of frameworks around how we might include young people as partners in our research. We'll have some guidance for young people around what they should expect and how to help them advocate for themselves when it comes to partnering up in research projects, and some guidance for ethics committees who I think get terribly nervous about the well-being of young people when it comes to suicide prevention research. So hopefully that will be reassuring for them as well. And we hope that those guidelines will really help facilitate the design of more effective and youth-friendly suicide prevention activities or research, and ultimately achieve better outcomes for young people. And I just left these two studies here just because these are some examples from our work of how poorly we do partner with young people when it comes to suicide prevention research so far. So just to wrap all of that up, as I said, unfortunately, rates of suicide and self-harm are increasing here in Australia. They're also increasing elsewhere in the world. So we're not on our own with this problem, but we do need to do a better job of redressing it. Evidence does suggest that there's a number of interventions that can be effective when it comes to reducing risk, but we do need more high quality studies and possibly a more systematic approach and strategic approach to suicide research. So really investing where we need research to be conducted. I think interventions really need to be delivered across settings. And as I've said, universal, selective and indicated interventions delivered in combination seem to yield the best results. But we do know that there are a lot of settings and a lot of populations that are so far underserved when it comes to suicide prevention research. So I do think we need to be filling some of those gaps. We've also learned that it can be safe and beneficial to involve young people as active partners in suicide prevention. And so young people do need to be part of the solution going forward. And I think if we can do that, we will start to do a better job of reducing some of the rates of suicide and self-harm that we're currently seeing. And on that, I would say thank you very much for your attention. Sorry, that was a bit of a whistle-stop tour, but I'd like to, as I say thank you for listening. Thank you very much to our funders. And also thank you to all of the young people that have taken part in all of our studies. Thank you.
Wonderful. Thank you so much, Jo, for that presentation. So informative, lots of information there. And it's so amazing to hear all the work you're doing. So I would now like to invite our audience for a question session with you, Jo. So we'll give the audience some time to start typing away their questions. So I believe you can type it in the conference platform or at slido.com. The code is 720731. So we'll wait a couple of moments for those to trickle in. Jo, it's exciting to hear about the Instagram Safe Chat page. I hadn't heard about that, and I work with a lot of young people who are very stressed because they have friends messaging them or posting online about self-harm or wanting to self-harm or that suicide. So I will definitely be sharing that page around. That's awesome.
Yeah, good. I mean, I think that whole piece of work really came across came out of the fact that young people were telling us that social media provided this really important platform for them to have these sorts of really tricky conversations or discuss these, sensitive issues. But they didn't know how to do it safely. And young people often felt ill-equipped, not only to sort of share their own experience in a kind of safe and respectful way, but they also got terribly worried when they saw their friends had posted content that made them, worried about them, but didn't know how to respond. And they were terribly worried that they might say the wrong thing and potentially cause further harm. So we really kind of felt the need to, to give them the tools and the skills that they felt they needed to have these conversations in a safe way. So yeah, ChatSafe's gone gangbusters. Definitely have a look at the Instagram page and, have a look at Twitter, because that will keep me kind of fairly updated on what we're doing.
Yeah, it's amazing. Such a great resource to equip young people rather than, feel too afraid. So very exciting. So I'll flick to our question page. Someone's asked if I would access the slides. So just to remind everyone, you can access Jo's transcript and more interviews with her in the conference section called Behind the Scenes. So you should be able to grab the content from there and also your conference booklets. There's lots of thank yous coming in.
It's a pleasure. Thank you for having me.
We're still waiting for those to be processed. I think something else, Jo, that stood out to me was, clearly you have a focus on self-harm and to take this seriously. I think a lot of schools, parents, emergency services can sort of view these as attention-seeking, sort of minimise self-harm, but, really pressing the seriousness of it, that it represents such psychological distress and exhaustion and burnout so severe, to not ignore it or minimise it, but to respond and to help. So
absolutely. And I think if there's one message that people can take away from all of this today is that if young people are expressing, engaging in self-harm or expressing suicidal thoughts or thinking, to not be afraid, certainly to take those seriously, but not be afraid to ask young people for a bit more information, to ask them what's going on for them, to really better understand the level of risk that people might be experiencing. And I know that there's been a bit of a hesitancy across the community up until kind of recent years anyway, to talk about suicide because people are worried that they might put ideas into people's heads or increase the risk. But we've certainly shown through our research and research from others from around the world that that's not the case. And I think there are lots of safe ways to communicate about suicide. And in fact, I would argue that it's unsafe not to ask those questions if you are worried about somebody. And we've certainly seen, I was in a meeting talking about it this morning, we've seen dramatic increases in levels of distress, psychological distress. I know it's come up on the Twitter feed following the conference over lunchtime as well. Young people's psychological distress as a result of the pandemic and the prolonged lockdowns and those sorts of things. We've seen dramatic rises in help seeking to our own services, to emergency departments for self-harm and suicidal ideation. So we really need to be taking that seriously and investing in the mental health and the mental wealth of our young people, I think.
Yeah, for sure. No, it's great. Even you saying that will hopefully equip people, give them the confidence. So I've refreshed and we've got some awesome questions. So Jo, we have a question here. Does Origin consider autistic youth to be more at risk of suicide and mental health issues? And what autism-specific training and interventions does Origin provide?
Yeah, so I think they're hard questions for me to answer, I think. So one of the reasons we started the body of work around autistic young people is because our clinicians came to us feeling like there was a lack of evidence-based resources and evidence-based guidance around how we can better support young autistic people. So I don't know that there are specific interventions. We've certainly got clinicians who specialise in working with autistic young people. And what they tend to do is provide additional support to the other clinicians that are working throughout our clinics. So we don't run a specific, to the best of my knowledge, we don't run a specific clinic here for autistic young people. But what we've got is our clinicians, as I say, who specialise in this area of work, who provide kind of secondary consultation and support to the clinicians that are working with those young people. I think there are particular risks and vulnerabilities for this population that we probably don't really fully understand, and we've not really, I don't know that our data collection mechanisms, and I'm talking nationally now, when we're looking at risk of suicide or self-harm, are sensitive enough to really be picking up the prevalence, I suppose, of suicide-related behaviour or the incidence of suicide in this population sensitively enough. But I do think there's a growing body of work going on at the moment in this area. So I think what I'm saying is kind of watch this space. It's certainly something that I know there's colleagues that are part of this conference that are really focusing on this area. And it's an emerging body of work for us here at Origin. So we're sort of still learning. I do think that this particular population will have specific needs when it comes to the kinds of treatment responses, and even just thinking quite crudely around the experience young people have told us that they've had in the emergency department, for example, when they present with self-harm or suicide risk, how counter-therapeutic that experience is. And I would suggest that that's amplified for autistic young people because of all of the, the variables that are associated with emergency departments, for example. So I think there are some specific needs, and we're only really just beginning to understand what they are and put some mechanisms in place.
Yeah. No, that's great to hear. And I guess that's part of the reason we're all here today, is to connect and not have things separate anymore, but coming together. So that's great. So we've got another question. Can you give examples of what being flexible in delivering mental health services to autistic young people may look like?
Well, I mean, this will come with a caveat that I'm not a clinician. I'm a researcher. So don't actually deliver any of the clinical services. But I do think, certainly from what young people have been telling us, is that we need to be a little bit flexible in the way that we do assessment. So we need to give young people some choices about how assessments are conducted, in terms of the language that might be used, in terms of the setting that assessments are conducted in terms of who's conducting those assessments and who might accompany the young person to come along. I think there are some kind of obvious sensory considerations that we might put into place in terms of our physical environments when doing that. But I also think, when there will be differences in how young people conceptualize risk, understand risk, process risk, and then are able to engage with things, for example, like safety planning activities or the types of therapies that we might use here at Origin, which is often very cognitive behavioral therapy based. And there will need to be some flexibility in terms of how those therapies are delivered, particularly in terms of kind of language, in terms of the amount of time that it might take for a young person to engage with care and be able to respond and process, the goals of care. I mean, certainly from some of Linda's work, what she showed was that took a little bit longer perhaps to really establish a meaningful therapeutic relationship between the young person and the clinician for some of the young people she spoke to. And I think, traditionally what we've been able to offer a kind of, a particular short window of care, certainly with the Headspace and our Medicare funded sessions, you get between 10 and 20 sessions for young people. Some young people, particularly autistic young people, might need more than that. We probably need to be embedding. I don't think we do a very good job necessarily of detecting the risk autism in young people. I don't necessarily think that some of our screening tools are as sensitive as they could be. We could be doing a better job of that. And I think, again, there's some work going on in other parts of our service that are trying to improve those things. So hopefully that gives you a bit of an idea of where our thinking is going. But I think there's probably a lot of expertise here that could probably also guide us, and we'd be keen to hear from people.
Yeah, awesome. Now we've got another panel later, but some of the ideas there are great in terms of feedback you've seen. Language, the modality of assessments, time, make sure there's time. So that's some awesome ideas. So our next question, is there research on how to best manage young people with self-harm and suicidality while on a wait list?
Oh, that's interesting. So just across the general population, I think this is something that's really challenging. But yes, there are studies that are looking at different types of intervention that might lend themselves to being delivered while young people are on a wait list. So we're looking at the moment at online therapeutic interventions. So I spoke briefly about the fact that online interventions have been shown to be safe and effective, or there's certainly evidence emerging for that. So I think there are some sort of online kind of interventions that could be used whilst young people are on waiting lists, and there are some studies starting to look at that. There have been other studies that they're not specific to self-harm or suicide risk, but they are certainly specific to youth mental health, that have shown kind of low intensity interventions. So things like exercise-based interventions and mindfulness-based interventions, those sorts of things that don't necessarily need to be administered by a trained practitioner, also lend themselves to delivery while young people are on waiting lists. The other thing where there's been, and waiting lists are a big thing at the moment, I know that there's such a demand for clinical services right now that we're not even able to meet our own demands at Origin right now. So I think it is really important that we are focusing on providing these young people with some sort of support while they're waiting for care. The other types of intervention that have typically been trialled post-discharge from clinical services are things like brief contact interventions. So there we're thinking about text messaging type interventions or traditional postcard type interventions. And I think they would probably also lend themselves to being delivered to young people while they're sitting on a waiting list. So sometimes just a brief crisis intervention or a brief safety planning intervention would be quite appropriate while somebody's waiting for care. So I think there's evidence emerging around that. But I think there's a real need for it, and certainly in terms of what we're seeing around waiting lists around the country at the moment.
Yeah, definitely. No, thanks for that question, Emily. And my private practice waitlist before COVID was 2 weeks, and now it's about 9 months. So yeah, there's definitely a huge need for waitlist support. And yeah, we're lucky in this day and age, lots of technology options available. All right, we've got about 5 minutes for some more questions. So how does intervention differ for autistic people whose suicidal attempts are more impulsive and are more a reaction to distressing feelings?
Yeah, well, I think the sort of short answer to that really is we don't know. There's no real evidence to guide us around what best practice should be when it comes to delivering interventions for this population. So again, as I said, I know there's a growing body of work that's starting to look at this. But in terms of interventions for people when they, are really in that kind of crisis period, that are specific to autistic populations, we just don't really know because there isn't a lot of evidence out there. Again, I would probably fall back to what we need are interventions that are going to provide a meaningful human connection, interventions that are going to, that young people might be able to engage in or manage, perhaps by themselves while they're waiting for crisis support and those sorts of things. So again, I would come back to things like safety planning interventions, those aftercare interventions. The other thing that I just might flag quickly is the development of what's being called sort of safe spaces. And they're alternatives to emergency departments for young people who are in a suicidal crisis or have made a suicide attempt. And the idea is really building on what I was saying before, that EDs aren't really an ideal environment for young people who are having a suicidal crisis, and particularly not an ideal environment for autistic young people. So the idea is that these safe spaces are a little bit more user-friendly. They would certainly be a better sensory kind of experience. And they're often staffed by not just clinicians, but a lot of peer workers. And I think that those sorts of interventions, they're yet to be evaluated, but I would suggest that they'll probably show quite a lot of promise.
Yeah, I agree. No, it'd be great to see more of those pop up. Thank you so much for that. So Denise has asked, are schools still able to be part of your Safe Talk initiative in the North and West?
Yes, Denise, where are you? What school are you from? They definitely are. Please just reach out and contact us. So our poor school-based study has been thwarted by lockdown after lockdown. But we are in the process of talking to schools across the North and West region at the moment, ready to onboard them for next year. So we'll be kicking off again in February. So if you are interested, just please reach out. I think my contact details were on the slides, but yeah, please just make contact and we'll definitely be keen to work with you.
Awesome. Yeah, no, Denise, you can find Jo's contact details as well in the conference booklet. So you can reach out there. Okay, looks like our last question maybe. Thanks, Jo. Has this work considered the needs of young autistic people who are either non-verbal or have little speech?
No, look, I think that's a really good question. And to be perfectly honest, we haven't been working with that population. So I think the young people we work with at Origin are obviously people who are seeking help for mainstream mental health services, if you like. So their primary reason for presenting actually are things like depression, anxiety, or early sort of first episode psychosis. So really, by definition, if people are presenting to our services, they don't have that level of autism, I don't think. So they are generally verbal and they're generally kind of out in mainstream education and those sorts of things. I think it's obviously an important population to be looking after, but it's probably not something that's really in our wheelhouse at the moment at Origin. So yeah, sorry, I can't really give you a better answer, but at Origin, we would really only be providing services to people who, as I say, are presenting with a different primary problem like depression or anxiety.
Yeah. Okay, thanks, Jo. Well, that brings us very close to the end of our questions session. Is there anything else, Jo, that you would like to add before we finish up this session?
No, I mean, I think just to say thank you for coming along. Thank you for having me. And thank you for the work I think that you're all doing, because I think, the bringing together of these two fields is really important. As I said, the work we've started here at Origin around young people who are autistic was really born out of a need that our clinicians were feeling. They really identified the gap. So I think the fact that we're starting to kind of work a little bit more collaboratively and work together across these two sectors is really encouraging. So no, I think that's it. Thank you.
Wonderful. Thanks so much for your time. Really appreciate it.